Hello everyone, my name is Jonathan and I'm just giving a very, very quick presentation on the new trial that we're going to be running throughout the entire hospital. This is mostly focused on the ICU perspective of the trial. This is the recovery trial, which is looking at identifying effective therapies for patients who've contracted COVID-19 infection. Dr. Mo Chaudhry is the PI, so he's the primary investigator, and myself and Pietro are sort of more just going to be helping with the ICU aspect of the trial. So I'm just going to talk to you a little bit about it, and so you just have a bit of a more sort of global idea of what's going on and what you do or do not need to do for these patients as they come through. So we're obviously dealing in the COVID-19 pandemic. This is the novel RNA coronavirus that is affecting many of our patients, and there's been lots of information that's come out, particularly from China and Italy, those centres that were hit sort of earlier on, about potential benefits or potential problems. We've seen information on steroids, hydroxychloroquine, acyclovir, Tamiflu, and now potentially Kaletra, which is an anti-HIV medication, but it's still not 100% clear which ones are beneficial, and so that is hopefully going to be something that the recovery trial will answer for us. So it's a prospective intention to treat trial, so it's going to be ongoing. It'll have interim analysis as we go forward, so we may be able to close aspects of the trial if the trial identifies clear evidence of benefit or harm. So it's a very straightforward trial design with 5 arms randomized in a 2-to-1 ongoing fashion. So double the number of people will be in the normal therapy arm compared to the others. So there's normal therapy where we don't change, we just do everything that we ordinarily would do. And then one group will receive Kaletra, which is a lopinavir-ritonavir combination for 10 days. The second group will receive nebulized inhaled interferon beta-1 alpha for 10 days. The next group will receive dexamethasone either intravenously or orally, and then the last group will receive hydroxychloroquine. So all the therapies run for 10 days, and they run for 10 days whether the patient is discharged from hospital or not. So if they discharged on day 8, they'll need 2 more days of their medication to be administered so that we can complete the information. At the moment at the Lister, we're not going to be able to deliver the Kaletra or the interferon beta-1 alpha yet. That may change. We'll have to see how that goes. So at the moment, the focus is only on the normal therapy, dexamethasone and hydroxychloroquine arms. So very straightforward inclusion criteria. It's really, really broad. Basically, you need to be an adult, so over the age of 18, have proven COVID-19 and not have anything specifically in the patient's medical past, for example, an allergy to one of the medications that would put them at risk of entering the trial. Hydroxychloroquine is associated with long QT syndrome, so that's another thing to think about. But otherwise, it should be very broad church. Almost all patients should be eligible to enter into the trial. The consent process, there's 3 forms of consent. The first is informed consent, which is as what we all know. So this will be a signed document following a discussion with the patient for those patients who come to us who aren't too unwell. The next is a next of kin consent, where if a patient is too unwell to give normal informed both verbal and then written consent, then a next of kin can sign on their behalf. Then once the patient has hopefully improved and recovered, we can then get informed consent from them. And the last is deferred consent, which is where a clinician who's not involved directly with the trial, so not me, not Pietro, not Mo, can then consent for the patient until we can get consent for the next of kin or informed consent later on. The information that we're going to take, there's not a lot of information. It's just some general identifiers so that we can track the patient through. The detail of the clinician who's got the primary care, so that will be their admitting consultant. The start date of their COVID-19 symptoms, any major comorbidities, and it's not ranked or anything, it's just yes, no, yes, no, yes, no. I think there are 5. The date of hospitalization and any contraindications to any of the treatment arms. So for example, if a patient did have an allergy to hydroxychloroquine, at the point of randomization, that's put in and they're automatically taken out from the possibility of being in that arm, but the other arms are still made available to them. And all we're looking at is all-cause mortality, so alive or dead, at 28 days. We then look to see what the presumed cause of death is. There are then secondary analysis looking at their hospitalization status at day 28, and also their discharge date, so therefore working out how long they were in hospital. It was any ventilation used, any advanced ventilation, and for how long. Was any renal replacement therapy, either dialysis or hemofiltration, used, and is that then ongoing? And then any serious events as are perceived by any of the clinicians caring for these patients are to be reported to the PI, Mo, who will then go through that event and see if it's relevant, and then if it is relevant, he will then report that up to the recovery trial. So this is more focused on what we need to do as intensivists. First of all, we just need to be aware of them. So it'll be important that we use the magnets on the board in our handover area so that we can identify those patients who are in the trial, just to make sure that we keep the main trial organisers in the hospital updated so we don't lose any patients. It's important that we continue their therapy. So there's going to be two groups of patients. There's going to be those patients who have been seen and managed by the acute medical team, who then deteriorate and come to ICU. And for those patients, it's important that we make sure we know which arm they're in the trial, and that we continue their therapy for the correct length of time, and that we report any adverse events. And we're hoping that the majority of patients will be recruited through by the acute medical unit. Now, obviously, there's a delay in patients getting COVID-19 swabs, so that might mean patients will be admitted to the intensive care unit as a suspected COVID, but only get their COVID positive report when they are in the intensive care unit, and so then we will be recruiting them. And there's also going to be those proportion of patients who come straight from the emergency department straight to intensive care, and we'll be recruiting through them. And myself, Mo, and Pietro will help if there's any issues with regards to the sort of the technical aspects of getting them consented or randomized. The therapies that we're going to be involved in will be arm 1, which is no change, so standard care. Dexamethasone, which is 6 milligrams once a day, either IV or oral, for 10 days. And hydroxychloroquine has a slightly unusual dosing regimen. It has a sort of loading period for 24 hours and then a maintenance dose. So the loading dose is 800, 800, 400, 400 in a QDS pattern. And then once that's been completed, they'll go down to 400 milligrams twice a day to complete for 9 days. Yes, and as mentioned before, do be careful in administering hydroxychloroquine in those patients who've got known long QT or torsade de pointes. And the main thing is less for us as intensivists, because it's unlikely our patients are going to be discharged home, but should they leave the unit before their 10 days is complete, we just need to make sure that on their drug charts that they'll have in the ward, that they complete the full course of the dexamethasone and the hydroxychloroquine. If you want any information, just head to www.recoverytrial.net. It's run by the University of Oxford. All the information you could possibly need is there, including consent forms, the randomization tool, and any other general information. There's plenty of little short YouTube video clips for you to read on that. And main thing is that thank you very much from myself and from the recovery trial organisers for all your effort and keeping a tab on this. I'm hoping that because of the very easy nature of the study, there shouldn't be a lot of additional work. It should just be a little bit of consenting and just a little bit of prescribing, and that should be it for the majority of it. And hopefully we can see if this will make a difference for our patients. Thank you very much.